Our final speaker, Dr. Carrie Henning-Smith, is going to delve into the timely topic of access to maternity care in rural areas. As we've discussed today, hospital closures and the loss of hospital-based obstetric services have had an impact on maternal and child health, and she's studying what this means for the future of rural OB care. She'll also suggest some practical policy solutions. Dr. Henning-Smith is the Deputy Director of the University of Minnesota Rural Health Research Center and an Assistant Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She is committed to advancing health equity, and her research focuses on improving the health and well-being of rural populations. We're pleased that she's with us today to share her important work.
Thank you, and thank you to NIHCM for hosting this webinar. I'm really excited to be a part of this conversation. I have the unenviable task of being the final presenter, and I really learned a lot from the first three presenters. Some of what I'll be sharing today will echo some of what we've already heard about access to OB care in rural areas, but I'm going to dive a little bit deeper, and I hope that that's useful for you both to talk about OB care, but also as something of a case study of care in rural areas generally. So before I do any of that, I want to acknowledge my collaborators at the Rural Health Research Center, especially Katie Casamano, who's really been instrumental in a lot of the work on rural OB care, and also our funders, the Federal Office of Rural Health Policy, who've been very supportive of this work. When we talk about maternity care in rural areas, it's important to think about who we're talking about and the context within which that care is provided. So just to ground us in that context, there are almost 20 million women of reproductive age in rural America, and 500,000 babies are born in rural hospitals each year. So this is not a small number. This is not an uncommon thing. We all know people who have given birth in rural areas, I'm sure, and we can relate to this in a personal way. But access to care generally for any type of service is a frequent challenge, as we've heard from the other presenters today. Contributing factors to those challenges include transportation, financial constraints, workforce shortages, and all of the other issues that we talked about today. I also want to put a caveat on everything that I'll talk about from here on out, which is to say that rural areas are not a monolith. They have always been, and they are increasingly so, diverse across a range of markers. And that means that the issue of access to maternity care doesn't impact all communities equally, but has disparate impacts in different communities. And I'll talk a little more about that in just a minute. I want to give us just a sense of some of these numbers, and Dr. James already shared some of these. I'm going to dig in a little more deeply and look to see between 2004 and 2014, what was the scope of obstetric services lost? And I also want to say, because I'm sure some of you are thinking to yourselves, 2014 feels like a long time ago already. So if you're thinking that, stay tuned. We are actively working on crunching more recent data right now, and we expect those results to be ready, hopefully within the next several months. Anecdotally, we do know that the losses have continued and that the statistics that I'm going to show you look a little more dire today than they looked even in 2014. So data for this study came from the American Hospital Association Annual Survey, Area Health Resources Files, and U.S. Census data. And using those data, we were able to look across different types of rural counties to see the scope of services and the scope of losses. So looking at micropolitan counties, generally those rural counties with about 10,000 to 50,000 people in them, that's too simplistic, but generally that's about what those counties look like. 82% of those counties had a hospital with obstetric services in it in 2004. That went down a little bit. It went down to about 78% by 2014. But where we really see a lack of services and where we saw the deepest losses were in those rural non-core counties, so our counties with the smallest populations, like King County that we just heard about, certainly a rural non-core county. Those counties started with 40% having hospital-based obstetric services in 2004, and that went down to 30% in 2014. And I'll show you a map of what this looks like. This map is published in Health Affairs if you're interested in digging in and seeing it for yourself. You can see across the country here, the white counties are the urban counties, and so we weren't looking at them. The darkest blue counties are those that had hospital-based obstetric services in 2004 and had lost those services by 2014. Those in kind of the royal or Dodger blue had no services whatsoever during this time period, and those in the teal color had continual services and still had services in 2014. A couple of notes on this map. The places that we are the most concerned are those places where you see contiguous counties lacking services. So it's one thing if your county doesn't have services, but you can drive a few miles over the next county line and get to a hospital with obstetric services. It's another thing entirely if you're in an entire group of counties that's lacking services. And also we know that counties vary dramatically in their size and their shape across the country. So you may be in a county that's very big and getting to the next county is no easy feat. And once again, I want to say that we know just anecdotally that the losses have continued since 2014, and so when we look at an updated map, it would look darker than this one looks. We would see more losses. So in looking to see which counties lost services, we also tried to understand what was associated with those losses. As I said, that rural areas are not a monolith. We know that not all rural areas experienced an equal risk of losing obstetric services. We found that the rural counties that were most likely to lose services were those that had lower birth rates. That makes sense. If you're having fewer babies born, it's certainly harder to maintain that fixed cost of keeping up an obstetric unit if you don't have the census to maintain it. We also found that counties with more Black residents, and specifically more Black women of reproductive age, were more likely to lose obstetric services. That should feel a lot less like common sense. That should feel like structural racism at play right there. We found that counties with lower median incomes were more likely to lose services, and that counties with fewer family practice doctors and OBs were more likely to lose services, some of the workforce issues and the financial issues coming into play there. So all of that may be fine and good if we don't think that there are any consequences from losing obstetric services. But of course we know that there are consequences to losing obstetric services. There are consequences to losing any type of services, and a service where you need to travel when you're in a particularly vulnerable situation like being in labor and needing to go and deliver a baby may be particularly consequential. And so looked to see what were some of the consequences, what were some of the changes after these counties lost obstetric services. These results are published in a paper in JAMA if you're interested in looking at them in more detail, because I'm only going to gloss over the results here in the limited amount of time that we have. The data here came from the same sources where we looked to see where there were OB service losses, but we also used birth certificate data to see where people were born. Were they born in the hospital? What did that birth look like? How was the baby doing after the birth? So our outcomes here were a change in out-of-hospital birth, and this might be a planned home birth. This might be a really happy occasion. This also might be an unplanned home birth, or in some situations, a birth on the side of the road. This is much less happy, not a situation that anyone would call ideal. And then we looked to see whether there was a change in births happening in hospitals without obstetric units. This is almost always a birth happening in an emergency room. Someone's showing up in labor and needs to get that baby out. And we looked to see if there were births changes in birth outcomes, and we primarily looked to see whether there was an increase in preterm birth or birth before 37 weeks. In the paper, you can read about some of the other outcomes, less prenatal care, increase in cesarean delivery, and low infant APGAR scores. But just to give you some sense of what we found that there was an increase in out-of-hospital births, and this is still a relatively rare occasion, but we found that it doubled from 1% to 2%, and that there was a bigger jump in rural counties that were not adjacent to urban counties. So if you couldn't drive next door to your next door county that was a city with a hospital and an obstetric unit in it, you were much more likely to see an increase in out-of-hospital births. And we also saw a significant increase in people giving births in hospitals without obstetric units. And again, that increase was much more pronounced in those counties that were not adjacent to urban counties. This was practically non-existent when counties had hospitals with obstetric units. It jumped up to about 3% after they lost their services. That's not ideal. We know that no hospital staff is looking to have people come in and deliver in the emergency room if there can be another plan in place, and no person thinks of that as their ideal birth plan. And then we found a change in preterm birth. We found just very small changes here, but significant changes. And preterm birth is the #1 indicator of, or the #1 risk factor for infant mortality. It's associated with risks of all sorts of other outcomes that we want to be able to avoid. And so even a small increase in preterm birth here is something to be really alarmed by and concerned about. So overall, we know that rural residents experience health disparities. We've heard a lot about that this afternoon already. And we know that not all rural people and places have the same opportunities for health. There are disparities across rural places, across rural people. But I would say that addressing maternity care as one of many issues that we want to focus on is vital for ensuring the health of parents, children, and the next generation of rural residents. And I'll give just a few ideas of where I think we may want to focus efforts moving forward. On the federal policy level, there's a bill that became a law just at the end of last year called the Improving Access to Maternity Care Act, and that's really focused on improving access to workforce, so getting more workforce in maternity care deserts. There's a bill that's currently in Congress working its way through the Rural, Maternal, and Obstetric Modernization of Services Act, which has a handy acronym, the Rural Moms Act. Again, that focuses on workforce, but it focuses on a whole bunch of other things too, supports for healthcare systems and families and communities to comprehensively address this issue. And then a federal policy effort, the Quality of Care Act for Moms and Babies Act, which is meant to improve quality and think about how we are analyzing and looking at the quality of care provided in maternity care. And so I think the federal policy efforts are really, really important. They're vital, they're needed, but we can't only look at those. We also need to think about state and local efforts to address maternity care issues in rural settings. No discussion of rural maternity care would be complete without talking about Medicaid, which plays an outsized role in funding births in rural areas in particular. And so thinking about Medicaid policy and Medicaid reimbursement rates that make it possible for healthcare systems to stay in the obstetrics business even when they have a low census is really important. State scope of practice laws are really important when we think about advanced practitioners, midwives, what are they able to do, how are they trained, what can they safely do, and how can we use them to improve access to maternity care. I'm just whipping through these. We could spend hours talking about any one of these here, and I'm sure some of you have already done that, but I want to just get a sense of some of these on your radar. And then in terms of additional state and local efforts, we've heard a lot about how we get a homegrown rural workforce and how we incentivize workforce to practice in rural settings. That's definitely as important for maternity care as it is for any other healthcare service. education and trainings and rotations that include obstetrics in rural areas. We already heard a little bit about residencies. That's so important. University of Wisconsin has been doing some really groundbreaking work in this area. How do we build capacity and training, especially thinking about those hospitals with very low volume, very low census, or those hospitals that have lost obstetric services but know that they may encounter a birth in the emergency room? How are people able to maintain their training and their competency in dealing with birth when and if it comes along? Telemedicine for obstetrics, what are the opportunities here for interacting with specialists remotely or for using technology to bridge some of these gaps? Not all. I think there are limits to what we can do with technology, but there's a lot of promise here for filling some of the gaps. And then training for law enforcement, EMTs, paramedics, and other first responders who might encounter births, especially knowing that we have an increase in people giving birth out of the hospital. Insurance regulations and costs. Malpractice insurance is certainly a big issue here, and whether or not that's affordable for rural hospitals is something of an open debate. And then finally, I think that we can't talk about this issue without talking about the impact on rural families themselves. And so are there supports in place? Is there housing or transportation subsidy in place for people who need to travel to give birth? Is there paid family leave if someone needs to leave children at home and travel to give birth for someone else and go back and forth between? I really don't think we do this issue justice if we only focus on the healthcare sector without talking about the families themselves. And I think that I am going to wrap up there with one aspirational goal here, which is to say that we are really, all of us, I think all the presenters on the call are working for workable solutions to the challenges that all rural communities face to improve access to care and quality of care, really with the ultimate goal of improving the health and quality of life of rural communities. So thank you, and I look forward to the Q&A here.